minimal hypermetropia and diplopia often associated with physical or psychological stress. Third is Balchowski type, which is seen in patient with myopia and convergent spasm. Fourth is refractive type, which is due to any uncorrected refractive error which is present in the patient already. And fifth is any intracranial pathology, which is a lesser common entity and it is most commonly associated with posterior cranial fossa lesion. So, purpose of this case was to highlight the importance of going through proper neurological assessment before diagnosing any case of acute acquired comitant esotropia, and particularly with CE-MRI and multidisciplinary approach. Coming to the case presentation, there was a 9-year-old male child which presented to the AIIMS Rishikesh OPD with acute onset inward deviation of right eye for 6 months, which was associated with diplopia and diminution of vision, and this history was given by her mother. And there was no significant history of any near work or excessive screen usage, no history of any occlusion therapy or uncorrected refractive error. Birth history was well within normal limits. At the clinical presentation, the deranged profile were color vision and contrast sensitivity, which were color vision were deranged and contrast sensitivity was decreased to 1.65, and pupils were pupillary reaction was ill sustained. Coming to the orthoptic workup, Hirschberg tests were right eye 30-degree esotropia with on cover test, on covering the left eye, right eye was taking the central fixation, and on uncovering left eye was maintaining the central fixation. And on alternate cover test, there was alternate fixation present. On stereo acuity test, there was 200 seconds of arc was present, and diplopia was present on WAT4 dot test. AC by A ratio was 3:1. Retinoscopy acceptance and fundus examination was well within normal limits. This was the pre-op 9-gauge photo of the patient showing right eye esotropia. CMRI brain plus orbit was done for the patient, which revealed that bilateral optic nerve tortuosity was present in the intraorbital segment. And then child was referred to pediatric neurologist for further follow-up, where he had undergone various neurological assessment to rule out any other associated intracranial pathology. VEP was done, which showed prolonged P100 latency in both sides, right more than left. As CSF analysis was done to rule out any infectious or autoimmune status, and a diagnosis of acute acquired comitant esotropia with bilateral idiopathic optic neuritis was made, and child was given methylprednisolone pulse therapy for 5 days. That was 750 mg in 100 ml NS over 1 hour, and tablet acetazolamide 250 mg, and then child was discharged on the tapering dose of oral prednisolone. And this was the post-IVMP ocular examination, which revealed that contrast vision was normal and color vision was normal, and contrast vision was improved to 1.89, which was previously 1.65. And VEP was also improved, but although it was prolonged, but it had improved from the previous reading, which was 130 previously and 110 in the current reading. This was the post-op 9-gauge photo. After 4 months, for which squint surgery was done, bilateral MR recession with bilateral IO recession after pediatric neurologist clearance, and there was no residual diplopia, and the child was asymptomatic. So, coming on to the discussion, this underscores the critical role of imaging, particularly CE-MRI, in evaluation of the patient with acute acquired comitant esotropia, especially when the etiology is unclear. And such cases often necessitate a multidisciplinary approach requiring neurosurgeon, neurologist, pediatric neurologist involvement for the optimal comprehensive management and patient outcome. And coming on to the conclusion, our experience differs from that of many other centers where Arnold-Chiari malformation and other intracranial pathologies were mainly involved. In this case, we observed optic neuritis as the leading cause of this pathology.
Okay, thank you.
So, what was interesting about your case?
So, at our center, it usually presented with other intracranial pathologies previously, like as astrocytoma or Arnold-Chiari malformation. But in this case, the optic neuritis was involved, and before taking a patient for the OT, we had to rule out any associate, because there was no clear etiology, to rule out any cause for the acute acquired comitant esotropia. So we went to the through CEMRI to rule out any neurological involvement, and we found out that there was bilateral intracranial optic nerve tortuosity with thickening of the segment.
Was there any change in the visual status after your strabismic surgery?
So visual status was previously 6 parts on Islanden, and after the surgery was also same, but on contrast sensitivity has increased and color vision was also improved for the patient.
So in the
And the child was previously prescribed refractive glasses, so child was doing fine with the vision.
at your center, do you how frequently do you send for CEMRI? Only if the diagnosis is not certain.
So usually, if the diagnosis is not certain, but we are thinking that we should go through neurological assessment before
Yes.
diagnosing any case.
Any case of secondary, any case which is secondary, usually you do ask for imaging for these cases. It may not be a CEMRI, but definitely ask for imaging.
Imaging to rule out any other pathology involved which is leading to the comitant esotropia.
Would you not do, so I don't understand. So standard practice is to do imaging, right, for these
Yes, ma'am.
cases which are secondary. So it is not because you don't have a primary pathology,
Yes, ma'am.
not congenital, you have it, it's started as a new condition, you will get imaging done.
Yes, ma'am.
So that is already highlighted, it's a protocol. Anyway,
Excuse
that's
me,
fine. I get
excuse
your
me,
point.
ma'am.
Yeah,
I just wanted to add to this case.
Sure.
Have you done the refraction in this patient?
Yes, ma'am.
Then atropine refraction?
Yes, ma'am. Cycloplegic refraction was done.
Okay, sometimes actually the cycloplegic refraction is not adequate. So to rule out the refractive accommodative esotropia component, you have to do the atropine refraction. Because that acquired esotropia could be because of this RAET, and you have to wait for the patient wearing the glasses with good compliance till at least 2 to 3 months before coming at a conclusion that it is not because of the RAET.
okay, thank you.